So, just by way of introduction, I am giving an overview of the new vaccines that are included from this year on most of them in the National Expanded Program of Immunization. But I've drawn extensively from data from colleagues listed below, Leslie Bamford from the NDOH EPI program, and from NICD, Chinoa, one of the epidemiologists in our unit, has done some of the analyses, and Marion helped with some of the costing data. And then some of the organisms, the vaccines I can speak to with more authority than others, because some are in areas where my day-to-day job in the Centre for Vaccines and Immunology at the NICD affords some exposure to that vaccine, but others I'm less familiar with. So I'm just apologizing in advance for not being able to answer all the questions that may come my way, but I'm very happy to refer onwards. So the new vaccines are these, highlighted in red in the schedule on the right. Firstly, diphtheria, tetanus, pertussis in pregnancy, which is a new addition. Then targeted hepatitis B birth dose, probably should have been around all along, but now is formally part of the program. Then the pneumococcal conjugate vaccine, the 10-valent serotype, has taken the place of the 13-valent serotype, the Prevnar. Measles-rubella vaccine at 6 and 12 months has taken the place of measles vaccine alone. And then the TD boosters that are given at 6 and 12 years of age have been replaced with Tdap. And then there are other non-changes that are important to talk to. The first is that OPV birth dose is still required, and I'll briefly mention that. And HPV is going to be one dose only, and I'm not quite clear if that's been promulgated yet through the EPI programs, but it certainly is a NAGI advisory for the coming up future. I'll also then end off with a little bit of extra information around surveillance for adverse effects following immunization, and the mechanism for that, and how that's conducted in the South African context. So tetanus, diphtheria, pertussis in pregnancy. Antenatal guidelines required that tetanus toxoid be administered to pregnant women in a 5-dose schedule. And you can see here a screenshot from the antenatal booklet, that the checklist of services. And one of the problems with this is that it was erratically and inconsistently administered across provinces. There were certain provinces in South Africa that did do this religiously and others that didn't. And there was also evidence that it really wasn't necessary for women having multiple pregnancies to be given 5 doses of tetanus toxoid in each pregnancy, particularly if these were the pregnancies were temporally closely related. So what's happened now is that Tdap, that's the same booster that will be given at 6 and 12 years, will replace tetanus toxoid. So it obviously contains tetanus toxoid, but it's also got diphtheria and acellular pertussis in co-formulated with it. The acellular pertussis toxoid. So the rationale for tetanus toxoid administration during pregnancy was that there was good evidence to show that it reduced neonatal tetanus. So that of course is it's not questioned, but there is evidence to show that pertussis vaccine administered during pregnancy can diminish or reduce the burden and particularly the morbidity due to pertussis in infants under the age of 6 months, who are particularly vulnerable during the first 6 weeks prior to the administration of the first hexasim vaccine. So South Africa transitioned from whole cell killed pertussis vaccine to acellular pertussis vaccine in 2009. And if you look at this data that's emerged from the Germs SA surveillance platforms and curated very nicely by Vanessa Kwan and the team who's on the call, you can see that there is an appreciable amount of pertussis that's picked up across the country, and more so in recent years post-COVID-19. And there are thoughts, and I'm really not the expert on this, that this transition from a wholesale killed vaccine to the acellular pertussis vaccine may have and may result in reduced longevity of immune responses or immunity or protection from pertussis, and hence the resurgence in older age groups of pertussis infection. This is less significance in older age groups, but if you look at the age breakdown of laboratory confirmed pertussis cases in South Africa from 2017 to 2023, you'll see that there's a massive number of cases in the under 1 year age category and in the 1 to 4 year age category. And this is really problematic because this is the age group, and particularly those children who are born premature. They have a high risk of complications and mortality even from pertussis. And so it's absolutely critical to prevent pertussis in this age group. So again, this data published by Nicole Walter and emerging from the Germs SA network has shown the incidence of pertussis in per 100,000 population by age group. And again, you can see 228 per 100,000 cases versus in older age groups 19, 8, 14, etc. And then that risk is also disproportionately allocated to HIV infected or exposed infants. And so we see that learning from the experience of others, and this data is shown from an Australian paper, that the administration of pertussis vaccine during the 3rd trimester of pregnancy reduces the risk of neonatal pertussis within the first 6 months of life. And so just deconstructing this graph here on the right, on the vertical axis is the vaccine effectiveness, and on the horizontal axis is the age of infants in months. So in order to generate a graph like this, you need to follow up a population, measure and conduct surveillance for laboratory confirmed pertussis cases, and then stratify these by whether or not the mom received pertussis vaccine during pregnancy. And particularly if you have narrow case definitions, you've got to look at where the timing of the administration of the vaccine in the pregnancy, and if given after 36 weeks, the efficacy in protecting the neonate is reduced. And then you've got to calculate the vaccine effectiveness using it's a simplified, or it's the formula is very much like the odds ratio equation, but then you look at the ratio of disease in those who were exposed to vaccine versus those who were unexposed, and you can see that the vaccine effectiveness is around 80% up until the period, or it declines to about 60%, and it only really reaches equivalence at 12 months of age. So you can see that, and this, by the way, this data is not unique. There's lovely data from the UK as well that has shown this. And so, ironically, you might want to ask, well, why have we not done this before? Because the USA and the WHO have recommended pertussis vaccine during pregnancy or maternal vaccination since as early as 2012. So this is about high time that we implement this in South Africa. So we really do hope that the provinces come on board and go full out to make sure that pregnant moms get this vaccine. So what do you need to know? Well, essentially all pregnant women should receive a single dose of this Adacel Quadro, is the tender that's been awarded, and the timing is 24 to 36 weeks, but even late or unboxed moms should also receive the vaccine. The efficacy for the infant will be lower, but there might be some sort of secondary protection because mom's immunity would be boosted and she may not get infected, and that may offer some protection to the child too. So it's given as an IM injection in the deltoid of the non-dominant arm, and there will be some minor adverse effects in terms of fever and injection site tenderness, but the adverse effects of this vaccine are very few. So then the next vaccine is that's new is the targeted hepatitis B birth dose. So why the change? Well, vertical transmission of hepatitis B is a phenomenon that is observable across the world. It is genotype related. So South Africa is dominated, and this is not on the slides, by genotype A, which although there's, I'm not familiar with the evidence, there's anecdotal evidence that this genotype tends to have reduced mother-to-child transmission rates. But nonetheless, it's been well shown across the world that if mom is HB surface antigen positive and surface and E antigen positive, in other words, she has active replicating hepatitis B, that the vertical transmission rate is around 70 to 90%. If mom is HBe antigen negative, but still HB surface antigen positive, the transmission rate is estimated to be about 10 to 40%. And all very well. What's the consequence of this? Well, 90% of vertically infected HBV infants develop chronic hepatitis B infection in the liver and have a shortened lifespan, and a quarter of them develop hepatocellular carcinoma or cirrhosis. So, of course, rolling out a vaccine like this is highly contingent upon identification of women during pregnancy. And hepatitis B surface antigen testing is a key intervention that will facilitate the administration of this. What's unfortunately critical is that if one is to be able to prevent vertical transmission amongst surface antigen and E antigen positive mothers, the intervention must be given within ideally 12, but absolutely within 24 hours to make any difference or to prevent transmission. And this implies that the testing of mom must be done way before birth and delivery. The other problem, of course, is that the time interval to try and arrange the immunoglobulin is also seriously curtailed. And so these need to be arranged way before the time of delivery. The data here in this table is very interesting just to show the efficacy of these interventions. The table looks at factors associated with infection status amongst infants born to surface antigen positive mothers. So you can see in the second row here that if mom is E antigen positive also, then there is a statistically significant risk that the infant will be surface antigen positive as well. And the numbers show you 12 versus 362 compared with 0 and 772. So there is a significant difference here based on the E antigen status. But other interventions that help are obviously the treatment of mom for hepatitis B. And you can see this didn't reach statistical significance here, but almost did. So it's still worth it. And probably this is related to maternal viral load. So if the maternal viral load is high, the risk of transmission then, of course, is much higher. And in this particular excerpt, it did reach statistical significance. So why the change? Well, we introduced in South Africa the HPV vaccine in 1995, and that means that next year, everybody who's under the age of 30 years should have been vaccinated, and that is a large proportion of the women of reproductive and childbearing age. And if we look at the NHLS serology data, there has been a progressive annual decrease in the hepatitis B surface antigen positivity by birth cohort. So if you look at this figure 1 over here on the right, you can see this is data from 2017 to 2021, arranged by birth cohort, and you can see the proportion test positivity of surface antigen, in other words, acute hepatitis, certainly decreases between the 20 to 24 and the 25 to 29 age category, which is where the group of vaccinated population would have been. The question is, why is it so high amongst these people who've supposedly been vaccinated? And of course, we know that our EPI vaccination coverage at best is around 80%, but could in some provinces be as low as 60%. And so if we have 1 million children born every year and we have a 80% vaccination coverage, that's still 200,000 children who are not vaccinated with whatever antigen they may have missed. And so these inadequate vaccination coverage stats certainly have a follow-on consequence for disease control programs. So the bottom line is that vertical transmission still exists in South Africa because there's a cohort of women between the age of 30 and 45 years who are still vulnerable to hepatitis B. And of course, we will still be living with gaps in our vaccination coverage in persons under the age of 30 years of age. So this data in figure 2 on the right looks at the positivity rate amongst various age categories of children, again from 2017 to 2021, looking at the proportion that tested HBs antigen positivity. And you'll see that there is a year-on-year decline across most age groups, which is reassuring. But there are still a significant proportion of children who are born with surface antigen positive, who test surface antigen positive, and these are probably those in the first year. Although it must be said that vertically transmitted hepatitis B is largely asymptomatic, and so it remains to us as surveillance folk unclear on how to interpret this data of HBs antigen positivity in children under the age of 1 year. And we'd really love to speak more with pediatricians to find out what kind of clinical presentations trigger this laboratory testing. So what is the broader context around the hepatitis B targeted birth dose? Well, WHO has established a 2030 goal to eliminate viral hepatitis as a public health threat, and by 2030, of course. And this includes reducing the incidence of HBV by 90% and reducing mother-to-child transmission by 90%. Now, one of the small problems that we have in monitoring these guidelines is that we don't have a clear picture in South Africa yet on what the incidence of hepatitis B is and what the vertical transmission rates are. So we're hard pressed to do some in-depth analysis of our hepatitis B data, which is underway at the moment, and then also to look at some modeling studies. And there is a research grant, a proposal that's funded to do hepatitis B testing on the HIV and syphilis antenatal seroprevalence survey bloods that were collected in 2022-23, and this has already been done for 2017's data. So we hopefully will be able to have some concrete data that can inform exactly the interventions that need to be done. Our South African hepatitis guidelines are a little bit controversial in terms of their implementation. They were developed in a rather aspirational way, without reference perhaps to some of the committees that are responsible for antenatal care, also for pharmaceutical management. And so there's been a bit of discordance between the rolling out of these guidelines for viral hepatitis and then the different programs and work streams that are required to fulfill this. So in the field, we've come to realize that there's controversy over the vaccination of pregnant women with hepatitis, there was a miscommunication or misinterpretation of one of the indicators of that are required for the management of pregnant women. And as a consequence, many pregnant women in some provinces are given hepatitis B vaccination if they are HB surface antigen negative. This is, of course, completely wrong. One should only provide vaccination once one has confirmed that an individual is HB surface antibody negative. In other words, one is vulnerable to infection. But the major problem actually is that the pharmaceuticals division in the National Department of Health only procured enough hepatitis B vaccine to safeguard occupational health workers. And then there was this guideline to provide vertical transmission prevention or targeted birth dose. And then there was misinformation around which pregnant women should get hepatitis B vaccine. And this has led to a shortage of hepatitis B vaccine for the people who actually need it. Hopefully this will be sorted out in the coming months or year. But the essential and the most important thing from a public health and an individual health level is to provide targeted birth dose to individuals, children who are born to hepatitis B surface antigen positive mothers, and of course to vaccinate healthcare workers as part of an occupational program. So here is a little bit of practicalities. Important to remember that hepatitis B vaccine is included in the hexasim vaccine, and that this hexasim vaccine is not given at birth, but rather the new tender is a standalone hepatitis B vaccine called Hep B Ped Cipla. And this vaccine with the old Heber Biovac on the old tender are interchangeable. They are the same thing. They are a hepatitis B surface antigen protein that elicits antibodies to hepatitis B surface antigen. It's a 10-dose vial, so it should be used within 28 days. And then the hepatitis B immunoglobulin is available from the NBI, but unfortunately the supply is intermittent. Probably tertiary hospitals should ensure that they have a regular supply on demand in the event of needing to administer this targeted birth dose. I'm not going to go into these details. The next vaccine is the conjugate vaccine, the pneumococcal 10-valent conjugate vaccine. So what has happened is that there's a change in manufacturer from the Pfizer or Prevnar vaccine, which is in the middle line, to the product called Pneumococcal, which is made by the SSI Serum Institute of India. And this has entailed a change in the number of serotypes that are included in the vaccine from 13 to 10. Now, this vaccine over here was the former vaccine, and you can see in this table the number of serotypes that are included and the mass of the serotypes, or the amount of each capsular serotype that is included as a target antigen for each serotype of pneumococcus. This over here is the new product, and you can see it misses serotype 3, 4, and 18C, which are included in the Pfizer vaccine. The reason this third vaccine over here is shown in this is because of the next slide, where I'll show you results of a study that were conducted comparing the middle vaccine, the Prevnar vaccine, with the GlaxoSmithKline Synflorix product. Now you can see this product is also a 10-valent vaccine, but it misses 2 serotypes that are included in the Serum Stratum Institute, and 1 serotype, serotype 3, that also was omitted from the other the SSI vaccine. But you'll also notice that the GlaxoSmithKline product has lower antigen concentrations than the SSI vaccine. And the reason that I show you this is to answer the question, what are the implications of losing 3 serotypes? Well, the bottom line is that the serotypes that are shown here, 18C, 3, and 4, in how many 5 years of surveillance by the NICD, spearheaded by Anne van Gotberg, and data collected and curated by the Germs Network, you can see that these 3 serotypes constitute a minority of the serotypes responsible for invasive pneumococcal disease. In fact, to quantify it, 3.5% on average, with a range of 1.4 to 6.2% per annum of invasive pneumococcal disease in children under the age of 5. So, in other words, the balance of invasive disease is caused by serotypes that are not in this vaccine. And then, importantly, there have been some prospective studies that have shown equivalence between the GlaxoSmithKline Synflorix and the Pfizer Prevnar vaccine. In other words, this 10-valent preparation versus this 13-valent preparation. Now, the fact that these the GlaxoSmithKline Synflorix preparation is equivalent to the Serum Stratum Institute was sufficient evidence for NAGI to recommend that this the swap between Serum Stratum Institute and Pfizer Prevnar preparation was not likely to have much impact in the South African context. So the other most important thing is that for this loss of coverage, there was a cost saving of nearly 150 Rand per dose that amounts to a total cost of 500,000. Sorry, look here, 500 million Rand to the National Department of Health. And so these cost savings can accrue towards the cost of adding these new vaccines into our schedule. And so this was the information that went into making this decision. Very importantly, just in terms of the changeover, Prevnar 13 and PCV10 Cipla are interchangeable. So if a child was vaccinated last year, received their first dose of Prevnar, they can easily transition to the 10-valent vaccine. And the new vaccine may also be co-administered with other vaccines, and that is a necessary prerequisite because our EPI schedule requires the first dose to be administered with hexacin. There are, of course, as with any vaccine, a limited number of adverse effects. So the next is the measles-rubella vaccine, which has replaced the measles standalone vaccine at 6 and 12 months. This is necessitated by us having to keep up with the rest of the world. We, in 2021, were one of 22 countries that had failed to implement the rubella vaccine. And this is probably because of a long legacy of other competing health priorities and reservations that introduction of a rubella vaccine in the context of suboptimal immunization coverage could lead to a paradoxical worsening or increase in congenital rubella syndrome. And there was good cause for this concern, but there's good modeling data now to show that if one implements the rubella vaccine in the context of, firstly, good vaccination coverage, and secondly, a wide age-ranging supplementary immunization activity, and the measles and rubella vaccine are combined, and that at every opportunity or every time measles vaccine is required, it is co-administered with rubella vaccine, one can theoretically, according to modeling data, eliminate rubella from the world. And my own personal feeling is that we may well eliminate rubella and to be, or find that rubella is the next virus to be eliminated. Rubella, like measles, has a single unchangeable serotype. There's no animal reservoir, and there's an effective and safe vaccine. In fact, the rubella vaccine is one of the safest vaccines in the world that we've ever invented. And so it may be possible. Rubella epidemiology in South Africa is very interesting. I forgot to update this particular slide, but we never saw rubella from 2020, 2021, and 22 because of the SARS-CoV-2 public health interventions. Rubella has a very low effective reproductive number relative to measles. Measles is 11 to 18, and rubella can be as low as 2, but can be as high as 6 in different contexts. And what happens then is that with a low reproductive number, one needs a very low, or there is a very low herd immunity threshold. And so the number of people that need to be immune to rubella is around about 75 to 80%. Whereas for measles, one needs to vaccinate 95% in order to reduce circulating rubella. So the intention in the switchover to include rubella vaccine is to firstly provide 2 immunization time points for rubella vaccine in childhood, and secondly, to conduct this wide age-ranging campaign from 0 to 15 years of age. And the department plans to do this in the between March, April, and May of 2026. So this is going to require immense planning to ensure good vaccination coverage. There is no change in the timing of administration. If you look in the package insert, the measles rubella vaccine of all production kinds, of all sort of, the opposite of generic proprietary preparations, should be given at 9 months to 12 months. But South Africa has been given measles vaccine at 6 months since 2016. The reason for this was the high prevalence of deaths and cases of measles in children during the outbreak from 2009 to 2011, where, 25% of children in the outbreak had measles during. Sorry, I just need to stop for a moment because I'm going to cough. Okay. Yeah. Where was I? Okay. So, yeah. So, the rubella. The question was whether or not we could give rubella at as early as 6 months, and fortunately, there was a study done just last year or the year before by in Denmark, looking at the safety and effectiveness of combined MMR given at 6 months. And this showed a fantastic side effect profile. What was in question was the effectiveness. And it was shown, I just have to stop for a second.
While we just wait for Kerrigan for a second, I've put the CPD link in the chat, so you're welcome to type. Oh, Kerrigan, I see you back. Your presentation, just when you are back, needs to be in presentation mode again. Yeah, perfect. Thank you. Sorry, hope you're feeling a bit better.
Okay. Yes, sorry about that. Yes, so the big question was whether rubella vaccine would be safe if administered at 6 months. And it was fine in this Danish study that had around 6,000 participants. But what was evidenced was that early administration of both measles and rubella had less than optimal seroconversion rates. So it was felt that while the safety was fine, there would definitely need to be a booster administered at a later stage. And in Denmark, this later stage is at 15 months. In South Africa, the later stage is at 12 months. And so what is problematic is that there is a fall off in the vaccination coverage between MCV1 at 6 months and MCV2 at 12 months. So the department is going to have to work extra hard to increase the coverage of both MCV1 and MCV2. So the next new vaccine is TD boosters being replaced with Tdap at 6 and 12 years. And why is this changing? Well, what we've seen over the last few years, and just an advert, the Center for Respiratory Disease and Medicine is hosting the AIRS workshop on Tuesday evening and Wednesday, and maybe Vanessa on the call can give the details in the chat. I'm not sure if everyone can attend. But there's some wonderful data to be presented at this around diphtheria across South Africa during the last 20 years, 10 years. And what we've noticed at the NICD is that there's been a resurgence of diphtheria. And this is not unique to South Africa. There's a global observation. And what we think is happening is that, number one, there's waning immunity in adulthood to diphtheria. And number two, that previously cutaneous diphtheria, which is often non-toxigenic, was boosting immunity in the adult population, but that for some reason there is a reduction in cutaneous diphtheria, and so there's no sort of natural boosting occurring, and children who often have had an incomplete primary vaccination series are susceptible to diphtheria in older age groups. And so the demographic of the cases of diphtheria that have been diagnosed in the last few years is often one of a child who's only had one or two of their primary doses, but more importantly, they've missed out on the booster vaccines at 6 and 12 years of age. The vaccination coverage for this age group is around 20 to 40% of the population. So it has not been very good at all. These vaccines have not been provided before the HPV campaign, have not been provided by school health programs, and so they require the children to be taken by a parent or caregiver to a primary health care clinic. And this has had a consequence of low vaccination coverage, and then is exacerbated by waning immunity. So what will happen is that this Adacel Quadra, the same preparation to be given in pregnancy, will be given to 6 and 12 years of age, and it will be administered as part of the HPV vaccination campaign. So in other words, by the school health programs. So the boys will get Tdap and the girls will get HPV and Tdap. It's a single dose vial IM injection in the non-dominant arm. So just briefly, some changes or non-changes. We absolutely need to give oral polio birth dose. There might be a change going forward in the next year or two to change the OPV timing so that it won't be given at birth. It'll be given perhaps within the hexasome schedule. But the bottom line is we still need oral polio vaccine. South Africa did include inactivated polio vaccine, that's OPV, in the hexasome vaccine that's administered at 6, 10, and 14 weeks. And while this vaccine will protect the recipient from paralytic disease due to polio, it does not prevent infection nor transmission due to poliovirus. So an individual who's been given inactivated polio vaccine can still be infected by and transmit oral polio vaccine or even wild-type poliovirus to other children, but they will do so without becoming paralyzed. In other words, there'll be a silent case, a silent onward transmitter. Now, you'll see from the figure on the right, which is outdated, but still gives you an indication of the problem, that we have circulating vaccine-derived polio type 1 in the neighboring country, next door, Mozambique, but it's also highly prevalent in DRC and in Madagascar. These viruses are created when oral polio vaccine is given into a community that has a less than 50% vaccination coverage with oral polio vaccine. And so what happens is the oral polio vaccine is transmitted from person to person to person. And as long as it remains in circulation, it accumulates mutations, which is part and parcel of what enteroviruses do. They mutate, and the number of mutations is proportional to the duration of transmission. If you have more than 50% vaccination coverage with OPV, there aren't enough susceptible people in the population to sustain chains of transmission, and the virus never can be around and replicate for long enough in order to back mutate. But where you have these districts and areas in the country that are highly war-torn and there's breakdown of social services, including vaccination programs, the vaccination coverage can be so low that you give an oral polio vaccine and it transmits onward from person to person. Now, the only way to stop this is to provide oral polio vaccine at 100% or as high as possible vaccination coverage, because this vaccine stops infection and replication in the enterocytes of the small intestine. And so you could almost say that IPV vaccine is a bit like the COVID vaccine. The COVID vaccine, remember, did not prevent infection, it did not prevent transmission, but it did prevent severe disease. IPV is one better than SARS-CoV-2 vaccine because it absolutely reduces paralysis. And the reason for that is it's given intramuscularly, and the antibodies that it elicits are active in the bloodstream and in the lymphatic system. And part of the pathogenesis of polio is that the organism infects the enterocytes and then has a viremic phase. And during that viremic phase, it lodges in the anterior horn cells and causes paralysis. So humoral immunity or antibodies in the serum prevents that viremic phase. But these antibodies have no effect on what happens in the enterocytes themselves. So in order to prevent transmission and to eliminate polio, actually, one needs this oral polio vaccine. And it's a bit of a double-edged sword because the oral polio vaccine is also the one that can then back mutate to virulence. So the problem in South Africa that we have is that although we have very advanced systems, because there are very few countries in Africa that provide 3 doses of inactivated polio vaccine, we do that, but we also have a neighboring environment where we have vaccine-derived poliovirus. And I haven't shown on this the cases of vaccine-derived poliovirus type 2 that have been isolated from the environment, in other words, from wastewater. So environmental surveillance is an integral part of polio surveillance, and we have detected in our regional reference laboratory at the NICD the vaccine-derived poliovirus type 2, which is the green dots that you see on this map, in both Botswana and in Zimbabwe. So these viruses are circulating in the communities on the border of our country. So we've yet to detect these vaccine-derived polioviruses in wastewater in our country, although we do have a very good surveillance network. But the point is that we are vulnerable as a population to polio, and we should not eliminate the use of oral polio vaccine until such time as our risk is acceptable for the importation of a vaccine-derived poliovirus. So just to say that the registration of the new tender for, or at least the new oral polio vaccine, is probably has been approved. In fact, I think it has already been approved. BioVac has been responsible for the registration process with SAPRA, and it can be administered through both public and private sector. The other change is the change from 2 doses to 1 dose of human papillomavirus. There's some lovely data, and I've taken a screenshot from a publication from PATH that shows a number of studies that have looked at the impact of 1 versus 2 doses of HPV and suggest that a single dose offers sufficient benefit. There is an exception to this, however, and this is that children living with HIV infection may not mount a sufficient immune response to 1 dose and need a 2-dose schedule. It does present a bit of a quandary for the school health program, because obviously HIV status in school kids is a highly sensitive matter, but it's been decided to rather than to ask children and their caregivers or parents whether or not the child is HIV positive, to rather inform the parents that the school health program will be giving a single dose and that the second dose needs to be administered at a primary healthcare clinic. So I won't go into this. What I do want to briefly talk to is the program for surveillance for adverse effects following immunization in South Africa. An adverse effect is defined as any health event within 3 months following immunization. So it's left open to the individual vaccine recipient and to the healthcare providers to decide if a health event constitutes an adverse effect following immunization. And the reason for this is that one wants to cast the net wide in terms of generating signals for post-marketing surveillance events. So we'll all appreciate as medical folk that the vaccine trials that are done as part of phase 1, 2, and 3 will rule out adverse effects that occur at a rate of 1 in 10, 1 in 100, and 1 in 1,000, and sometimes 1 in 10,000 dose administered, but they may not pick up adverse effects that are more rare. And this is because the denominators of people that are involved in these vaccine trials tend not to go more than 10,000 persons. So all of that to say, and I have to cough again, that the post-marketing surveillance is very important. We do need pharmacovigilance and strong pharmacovigilance systems. And this diagram over here shows how in South Africa we have a surveillance system. We have a case report form and a case investigation form that may be found on the NICD website. If you go to the NICD website and you go to diseases A to Z and you look under A, adverse effects following immunization, you'll find these paper case reports. You can also notify cases through the Med Safety app, which is an application, the link to which can be found on the SAPRA website. Anybody may notify a case, a member of the public also, and these cases are detected, and the database for these is monitored at the moment by the Department of Health, but SAPRA is going to take this over. SAPRA also collates adverse effects from the vaccine manufacturers. And then there's a committee, the National Immunization Safety Expert Committee, that reviews the more serious adverse effects to establish causal assessment. At the NICEC committee, we use a algorithm determined by the WHO to establish causality. So essentially, it just goes through the empiric logic of could this case have been caused by another medication or another circumstance? Could it have occurred at a background rate? Could there be another explanation for the case? And there's a whole set of questions that need to be answered in order to come to some kind of meaningful interpretation of the case and whether or not it was caused by the vaccine. So surveillance, of course, is important in EPI, surveillance for adverse effects and surveillance for the EPI conditions themselves, so that we could monitor program effectiveness. And so here are the links that I was talking about for the case notification and the med safety app. So Jeremy has this presentation, the links are in it, and you're welcome to use the presentation if you need, and any of the slides in it. This data over here was produced by Chinoa, our epidemiologist at the Center for Vaccines and Immunology. She looked at the adverse effects that were reported for the COVID vaccines during and after the COVID pandemic, and essentially showed that our surveillance system was able to pick up the adverse effects that were listed in the package insert and generate what we call pharmacovigilance signals for these adverse effects, which was very reassuring because it means that our surveillance system works. However, what we did notice was that there was a much lower, about a 10-fold lower incidence of these adverse effects in our population than elsewhere, and that signals significant underreporting of adverse effects following immunization. So please do your bit. Report adverse effects following immunization, especially the more rare and severe ones. And then a last note about surveillance for vaccine preventable diseases. The NICD is tasked with doing this, and you'll probably all, at least I hope you are all familiar with the notification tools that may be found on the NICD website at the link in the bottom of the slide. The data that you share with us then is integrated with the NHLS laboratory testing data and with the private sector laboratory testing data, and it is then collated into a report. And the various data streams and pathogens go to the various centers within the NICD, and we each are responsible for reviewing, say, at the Center for Vaccines and Immunology, we are responsible for reviewing the measles, fever, rash, the rubella, and the hepatitis notifications, and say the Center for Respiratory Disease and Medicine monitors pneumococcal and Haemophilus notifications, etc. So a lot of people's time and energy goes into monitoring these surveillance data because they form the bread and butter of the interpretation of the effectiveness of our disease prevention programs on the one hand, and they also help us not be aware of outbreaks and potential interventions that can contain these. So this is an example of a report. You can see that in January of 2024, there was lots of malaria in Gauteng, and fewer cases of malaria notified from Limpopo and Mpumalanga. And measles, there was lots. Measles and rubella go together in terms of their notification. So you often see that these numbers are the same. And there was actually a rubella outbreak in the early part of the year in the Western Cape, and you can see that reflected on our NMC. So final word of thanks to those who helped prepare this, and thank you to you for listening. And I think there's a bit of time for some questions.